Welcome to another version of LINNC Paris 2024. I have the honor, privilege to introduce someone that doesn't need further introduction. Clinical trialist, interventional neurologist, Dr. Raul Nogueira, UPMC, University of Pittsburgh Medical Center. I'm going to ask you several questions about the challenges that we have nowadays to treat large core patients and endovascular thrombectomy on those individuals. So welcome.
Thank you, Daniel, for the kind introduction. It's a pleasure to be here to talk about what I consider one of the biggest advancements that you have in stroke treatment over the last 2 years.
Absolutely. So Raul, there is definitely a lot of excitement, or there's been a lot of excitement in the last year, especially with the publication of LASTE. I mean, nowadays we have 6 different trials: Tesla, LASTE, Tension, Select, Angel Aspects, and Limit Rescue. Well, we have the 6. All of them follow similar protocols. The last one, LASTE, has included individuals with aspects of 0 to 2. And only 30%, approximately 30% of the enrolled individuals received intravenous thrombolysis. How do we assess the risk in those patients when we decide to enroll them and they are treated with IV-TPA or TNK?
So I think this is a question that very likely it's going to be better addressed by the pool analysis of the trials. Right now, it's I think the better guidance that we have, it's the IRIS meta-analysis. As you know, there were patients with aspects 0 to 5 in IRIS. They aren't many. And even though what was done in the subgroup analysis was the comparison of the patients of aspects 0 to 5 versus aspects 6 to 10, right? And there was a trend towards an interaction, meaning the p-value was less than 0.10, like 0.10. And many people criticize when it's not statistically significant, it's just a trend, but I think it's fair to value that in the clinical setting sometimes, mostly if there is a strong biological plausibility, right? And then the advantage versus disadvantages of your decision, they aren't very big. So what you know now about the question of giving thrombolytics prior to thrombectomy is that there is not a remarkable benefit, okay? It's not a panacea, okay? There may be a benefit, that benefit exists, I believe, but it's relatively small. But also there isn't a risk. So I think we should try to develop the situations where you have the black, the white, and the gray. And I think the white, meaning you should almost always give intravenous thrombolytics, is time. We know that in general, in the first 2 hours from symptom onset, there is a statistical significant benefit in IRIS. So for those patients that come to my center very early on, for 2 hours or so, I think my tendency is to always, whenever I can, I'll give lytics. None of those patients will have aspects that it's very low, because within the first 2 hours, it's extremely rare to have a very low aspects, right? So I think that's a wide situation. Then there is the situation that's closer to black, where I have a tendency not to give. We know that after 3 hours, the point estimate is now favoring direct thrombectomy, skipping the thrombolytics, okay? So I think after 3 hours, if there is a benefit, that benefit is a lot lower. And after 3 hours is also the time that I'm going to start having these lower aspects. So if I see a patient with aspects 0 to 5, okay, and specifically if it's after 3 hours, which tends to be the case, I think it's very reasonable to withhold thrombolytics if the patient is presenting to a thrombectomy capable center and my team is ready to go, right? If this is a transfer case in outside institution, I think it's a different situation. You have to, adhere to guidelines. Aspects shouldn't be used as a reason not to thrombolyze someone who doesn't have immediate access to thrombectomy. But in the IRIS meta-analysis, even though the interaction of aspects versus thrombolysis or not thrombolysis prior to thrombectomy, it wasn't statistically significant. That was this trend. So I tend to value that, and in my practice, I tend to withhold for these low aspects. We will know more after the pool analysis, I believe, of the 6 trials, as you suggest.
We've seen that the median modified MRS or modified Rankin scale, it's in most of the studies, it's 4. In LASTE, the NNT is 4 point something. So we need to treat 4 individuals to get certain benefit on 1, if we interpret it that way. And so, can you walk us through the concept of prognosis versus real treatment effect? How are we impacting these populations? We know and we understand we are decreasing or lowering disability. Are we decreasing mortality? Can you walk us through that?
Absolutely. So I think you're touching now in what historically has been one of the biggest problems in our field. If you trace a parallel between stroke, neurology, and cardiology, and in the interventional procedures, we start, by and large, by doing single-arm trials. When you do a single-arm trial, you are comparing a patient that had thrombectomy with another patient that has different characteristics that also have thrombectomy. When you compare patients that were treated, right, you just have that one arm, the only thing you can do is establish the predictors of outcome. And yes, age, aspects or stroke size, time, these are all bad things, right? The older you are, the worse is your outcome. The lower is your aspect, the worse is your outcome. The later you are, the worse is your outcome. But now you finally have the benefit that cardiologists have had for decades, which is randomized clinical trials. So when you do a randomized clinical trial, I can compare patients that are similar but treated versus no treated. So when you do that, you can establish what really matters for the decision making, which is the treatment effect modifiers. And age doesn't nullify the benefit, it doesn't modify the treatment. If anything, even though the older patient does worse with treatment than the younger patient, okay, without treatment, they do so much worse than the younger patient without treatment that the difference between treatment and no treatment might be even bigger in the older patient. So yes, young age is good for prognosis, but actually older age might be actually better for treatment benefit. So I think this helps us understanding, right, this difference between prognostication, your chances of doing good, versus your chances of benefiting. Think of predictors of outcome answering the question, who's gonna do well with the treatment? Versus treatment effect modifier, answer the questions that really matter. Who's gonna do better with the treatment? Because sometimes you are way too far in the ischemic process to do well, but with treatment you're gonna do better than if you don't treat that patient. So there is a benefit, and you should consider treating these patients. And this, I think, it's a very important concept for us to understand, mostly because oftentimes what you are doing to our patients, even with large core, if you don't treat them, the vast majority is gonna live.
Right.
But they're gonna live with a higher degree of disability. So it's almost like the decision should be, you let these people die with the understanding that even in large core trials, the mortality range between 20% in angio aspects to 40% in select 2. And even at a year, mortality in select 2 control group in a year was 52%. So what happens is the majority of the patients, right, that was the highest mortality trial, all the others were lower, the majority of the patients will be alive, right, with a large core. But they will be alive with a higher degree of disability because you didn't treat them. Yes, they are a 4, but they could have been a 5, which is worse than death in the opinion of many people. And if they would have been a 4, now they are the 3. If they would have been a 3, now they are the 2. But yes, very few people, right? Maybe 1 in 5 at most will be a 2 with this large course.
So along those lines,
2 or less, I should say.
Along those lines, we have discussed dominance, potentiality to recover, to participate in rehab. Some of the trials have not considered dominance in involvement of right or left hemisphere in their subgroup analysis. Why is this?
So this is a great question, and I think it's something that we should look into when these pool analyses are conducted, right? Whether it's a predictor of outcome or a treatment effect modifier. Keep in mind that what really should matter here is whether it's going to be a treatment effect modifier, which I don't believe it will, right? Because you're going to save more brain tissue if you rescue the patient within limits, of course. So what we know about this is from past trials, the right-left doesn't really have a big impact in terms of treatment effect modification. And there is actually a suggestion that non-dominant lesions, because patients develop neglect and anosognosia, they don't even recognize they have a problem, they don't engage as much in rehab, and those people may actually, despite not having as much of a language problem, they actually much have worse outcomes overall. So I'm not so sure that the right-left discussion should be a determinant on our decision making. I think family expectations could be a determinant, right? So in particular, if you have an elderly patient, right, that says, I only want to live if I'm going to be normal, very close to normal. And you establish that the chances in that age group, it's going to be 1 in 10 or less, which is probably going to be the case when you look at specifically at the elderly, right? Because again, even though they benefit, they have worse prognosis. It's reasonable to have a conversation with the family, but the decision there is you either treat the patient or you make the patient comfort measures only. If you are in between, you are doing the worst thing you can for that patient, because there is a good chance he's going to be alive, probably a higher than 50% chance, right? But worse degree of disability, right? And you don't want that 5. It's probably better to accept a 6 than a 5 in a patient that has manifested that doesn't want to live with a bad quality of life.
And so I think some of the biggest challenges that we all face right now, and not only in the US, but also in Europe, is to convince the administrators and systems of care, and modify systems of care, that there is a real treatment effect, that we actually can lower disability, and then there is a potential shift in socioeconomics. This is not going to happen until we modify and update guidelines. What does it have to take? What are we waiting?
I think, well, I'm sure they've been developed the updates as we speak by many colleagues in Europe and the American Heart Association. We're going to see, the local guidelines changing. I think the data is very clear. Out of the 6 trials, Tesla was the only one that didn't achieve the pre-specified primary endpoint, but the overall results are also positive. Sometimes it's a little bit of a gambling which primary endpoint you use, and they essentially achieve almost everything else.
And the numbers were almost there.
Yes, exactly. So it's just a random thing, right? So it's very, very consistent, right? And I think it's time for us to reflect. There is what I call strokeophobia, okay? You don't see this happening in STEMI, heart attack. Oh, maybe I shouldn't treat this patient because the prognosis is poor, because he's too old, this treatment is expensive. The mortality in cardiogenic shock, it's around 40%. You don't see this happen in emergency medicine or critical care medicine with a patient who has severe sepsis or septic shock. You don't say the Apache score is too high, prognosis is bad, Antibiotics, vasopressors, intensive care unit, very high cost. I'm not going to treat this patient. It doesn't exist, right? Mortality of septic shock is around 40%, right? And then we can talk about trauma, where you invest everything to sometimes find out that the patient's even brain dead. And there is a good justification, maybe organ donation, but sometimes that's not even the case. Time-sensitive diseases that have a strong treatment benefit, you have to treat first, ask questions later, unless there is an a priori decision of the patient family that they prefer to die, right? And think about oncology. You're talking about costs. They have these very expensive chemotherapeutic agents that sometimes prolong life for a few months, and that's perceived by society as, again, as it should, life is very precious. So why you have this strokeophobia, right? It's like the standards for all these decisions in stroke, and you have had cost-effective studies, one after the other, demonstrating it's one of the most cost-effective treatments you have around, right? And this keeps going, right? It's a debate that keeps going. So I think part of the problem is you just need to change the way you perceive stroke. You have to look at the stroke very much like as a heart attack, as sepsis, as trauma. Okay, this is an emergency. There is a huge treatment benefit. You have to treat these patients. If you don't treat them, chances are they're gonna stay alive, but with higher degree of disability. And by doing so, we're actually gonna have more costs.
Oh, absolutely.
With more hospitalizations, outpatient care, a burden to family, the caregivers, right? Right, someone in the family, mostly in places where I come from, right? Someone has to stop working to care for the family members. So it's a huge burden to society, probably much more than the other conditions that would kill a patient. In general, thrombectomy, it's not a life-saving procedure. We say it's a life, it's most of the time thrombectomy, it's a disability-sparing procedure. The exceptions are basal arterial occlusion, it saves life there. The ESCAPE trial, only the subset of the elderly patients older than 80, they had a benefit in terms of mortality. And now we have LASTE and tension also suggesting that large core, these are the more like earlier trials, right, may have a benefit in mortality, but SELECT2, no difference. Angio-aspects, no difference, right? So it may be that the later time versus the early time, but and if you look at Hermes, no mortality benefit. Aurora, no mortality benefit. So it's important that you make the governments understand that, you know, many of these people will stay alive, but with higher degree of disability. And as you go up on MRS, but you stay alive, you are consuming more resources and being a bigger burden to society. So that upfront cost, right, to do that procedure, is essentially pennies compared to the costs you're gonna have for the remaining of the life of these patients. And I'll conclude this point by adding that, so you can say, well, how maybe at 90 days, many of these patients didn't die, but at a year, they all be dead, so they will cease to be a burden to society. The SELECT2 paper of the 1 year follow-up makes us think otherwise. Mortality was 40% in the untreated patient at 90 days. At a year, it was just 52%, 12% more. But you still have half of those patients being a burden, right? And if you could have shift the outcomes to less disability with an NNT that it's so low, as you said, I think that's the right decision.
Well, it's very important that you mentioned that there is actually a 1 year follow-up of SELECT2 and understand these concepts. Raul, thank you so much for this enlightening conversation, for having this progressive vision and sharing it with all of us. We're looking forward to participating of your contributions and learning more from you.
Thank you so much. It was a great pleasure.
Thank you. I appreciate it.
Thank you.